Hello, welcome to our section Paper Flash, where we will review the most relevant scientific articles in cardiology with the help of flash animations and the CASP clinical trial critical reading method. Join us! As you can see, today we bring the ISCHEMIA study. The ISCHEMIA study is the biggest clinical trial that has ever been made in order to compare coronary revascularization versus conservative medical treatment in patients with moderate or severe chronic ischemic heart disease. For this reason, it is not only advisable to take a look at the paper, but also to review some technical considerations, such as, for example, the study design, methodological soundness, obtained results, and their transcendence. And for that, the CASP method proposes 11 questions that will help us get the most out of reading. Let's begin. Does the clinical trial answer a clearly defined question? As you know, this is not the first time that the results obtained with coronary revascularization have been compared with conservative medical treatment, as some clinical trials carried out at the beginning of this century suggested that revascularization did not offer advantages in terms of reducing deaths or myocardial infarctions. However, there were many hypotheses that sought to explain these results. For example, that drug-eluting stents were not used, that the percentage of patients with severe ischemia was small, or that patients with complex lesions were excluded in order to guarantee their coronary revascularization. Thus, the ischemia study aims to dispel all these doubts, and for this, it proposes a specific scenario. This is none other than the stable chronic ischemic heart disease with patients who have demonstrated moderate or severe myocardial ischemia. In this way, a specific question arises. Can modern coronary revascularization techniques offer any extra benefit in terms of mortality and major cardiovascular events with regards of conservative medical treatment? And with this, we give our first like to the paper. Was the assignment of patients to each of the groups random? Indeed, the patients studied were randomly assigned to each group by means of a computer system, maintaining a 1-to-1 ratio. In one group, the patients underwent an invasive strategy, which included optimal medical treatment, cardiac catheterization, and percutaneous or surgical revascularization when appropriate. In the other group, patients only initially received optimal medical treatment, reserving cardiac catheterization only in case of therapeutic failure. So we have to give this question another like. Was the follow-up of the included patients adequate? Yes, as described in the paper, 8,518 patients were initially enrolled, but 3,339 were discarded for having any of the following conditions: severe renal failure, recent acute coronary syndrome, left main coronary artery disease, severe left ventricular dysfunction, heart failure in functional class 3 or 4, as well as angina refractory to medical treatment. Thus, 5,179 patients were included in the study and divided into two groups: 2,588 for the invasive strategy and 2,591 for conservative management. Finally, the patients were reviewed periodically, assigning the first visit at a month and a half and the following reviews at 6, 9, and 12 months. Thereafter, the reviews were performed every 6 months until completing a mean follow-up of 3.2 years in both groups, which represents 99% of the initially planned follow-up time. For all these reasons, we give another like. Was there a blinding? After reviewing the paper in detail, it is impossible for us to confirm the existence of a blinding process. So, for this reason, we assume that this was not carried out. And although we can understand that the patients or their cardiologist could not have been blind, with respect to the assigned strategy, the analysis of the data by the researchers could have been blinded. In this way, we have the first dislike of the paper. Were the groups similar at the beginning of the trial? Yes, indeed. An extensive list of baseline clinical characteristics has been perfectly described in both groups of patients, and after their comparison, it is clear that there are no significant differences that could condition the results obtained in the study. For this reason, we assigned a new like. Regardless of the study intervention, were the groups treated identically during the trial? The researchers assured that the only significant difference between the two groups was the performance of early cardiac catheterization and possible coronary revascularization in the corresponding group. However, when we review the information available about the drug therapy that both groups should receive, some questions arise for which we cannot find answers. As you know, secondary prevention of ischemic heart disease comprises a set of pharmacological and non-pharmacological strategies that are used with the aim of controlling symptoms, improving the quality of life of the patient, and improving the vital prognosis by reducing major cardiovascular events or directly reducing deaths from cardiovascular causes. In this way, and according to the information available in the supplementary tables, we can only assure that there were no significant differences between the two groups with respect to the administration of beta blockers, calcium antagonists, a non-specific group of anti-anginal agents, and antiplatelet agents. However, this clinical trial aims to find differences between both groups based, above all, on strong endpoints, such as death or major cardiovascular events. So, as you can suppose, the consumption of beta blockers, calcium antagonists, or other anti-anginal drugs cannot guarantee absolutely nothing with respect to the primary objectives of the study, since these drugs only offer benefits in the control of symptoms, while, for its part, we are told nothing about the percentage of patients who, within each group, were subjected to other secondary prevention strategies that would have an unquestionable influence on the results obtained. For example, the consumption of statins or the application of cardiac rehabilitation programs. For this reason, we have to get another dislike. Were the results obtained adequately described? Affirmative, since, as we have already mentioned, the objectives of the trial are clearly identified in the main paper and defined in the appendix. These are mortality due to cardiovascular causes, myocardial infarction, hospitalization for unstable angina, heart failure, cardiac arrest, and changes in quality of life. Furthermore, they explained that it was necessary to change the definition of infarction during the course of the study due to the low rate of events, and that this could have penalized the revascularization arm. Finally, it is perfectly described how the statistical power of the study was calculated, the number of patients that had to be recruited, the necessary follow-up time, and the statistical methods of hypothesis testing used. In this way, we have another like for this study. What results were obtained and what is their precision? After comparing the results obtained between both groups, that is, the invasive strategy versus the conservative strategy, and using 95% confidence intervals, no statistically significant differences were found with respect to the primary and secondary endpoints initially expected. So, in this respect, the paper earns another like. Do the benefits that can be obtained with the intervention justify the risks and costs assumed? Of course, because in this case it is not a matter of testing an unknown intervention or of assuming an unpredictable health or economic cost, but rather of identifying the best therapeutic option from two universally accepted strategies used in our daily clinical practice. For these reasons, we have another like. can the results obtained be applied in our daily clinical practice? As you can see, the clinical profile of the patients who have been studied in this clinical trial is comparable to a significant percentage of the patients that we usually encounter in our daily clinical practice. So, of course, the results obtained can not only be extrapolated to our environment, but will help us make more efficient use of our healthcare resources. So, we have another like. Does the proposed experimental intervention offer extra benefits over current interventions? Taking into account the results of this trial, conservative medical management seems to be the most cost-effective therapeutic strategy that we can use in those patients with stable angina, regardless of the degree of ischemia they present, leaving cardiac catheterization and the possible coronary revascularization only for those patients with refractory angina. However, and remembering the exclusion criteria, the results of this study cannot be applied to all the patients in our environment, as there is a very important subgroup of patients that are not reflected in this paper. We refer to those who present a left main coronary artery lesion, severe left ventricular dysfunction, heart failure, among others. In addition, with the results obtained, the role of the ischemia provocation tests or non-invasive stress tests is mentioned, since according to this study, it seems that they are irrelevant when choosing a therapeutic strategy. Finally, in our opinion, there are doubts regarding the strategies used in both groups in order to exercise secondary prevention of ischemic heart disease. We refer specifically to those with prognostic impact, such as statins or cardiac rehabilitation, because nothing is said about it, and we cannot assure that there are no significant differences in this regard between both groups, differences that in some way may condition the results obtained. Perfect, we have finished the review, and now we just have to take a look at our likes counter. As you can see, we've got 9 likes, not bad for our first paper. In this way, we can affirm that the ischemia study is a solid clinical trial from a methodological point of view and interesting from a practical point of view, with clinical results that can be extrapolated to our clinical practice as long as some considerations are taken into account. In this way, we say goodbye. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye.